Hello everyone, I'm Dr. Lahari this side, and this is the second part of ulcerative lesions of the oral cavity. The learning outcomes, as discussed in the previous lecture series, that means lecture part 1, are same: is to define an ulcer, to classify oral ulceration, and to differentiate different oral ulcerations based on their clinical presentation. The clinical classification of ulcers, as given by Behcet's oral medicine, is divided into acute multiple lesions, chronic multiple lesions, recurring oral ulcers, and single ulcers. So we've had gone through acute multiple lesions in the previous lecture, and now we will look at all the others in this lecture. So let's start with recurrent multiple ulcers. The most common example for a recurrent ulcer is a recurrent aphthous stomatitis. These are ulcers that are confined to the oral mucosa in a patient with no other signs of disease. So essentially, it is a diagnosis of exclusion. Aphthous ulcers affect 20% of the population, which is a very big number. They are clinically classified as three types: minor, major, and herpetiform. Minor ulcers form 80% of the clinical ulcers that are seen. Major ulcers are also called as Sutton's disease or periadenitis mucosa necrotica recurrens. These are examples of how the minor, major, and the herpetiform ulcers look like. The minor ulcers generally are zero point 0.5 to a maximum of a 1 centimeter in size, generally lesser than that size. They could even be tiny pinpoint ulcers, and you would generally see one or two ulcers, or maybe few, about 5 to 6 ulcers in the oral cavity at a single point in time. The major ulcers are larger in size, can have irregular borders. They are also shallow and surrounded by erythematous halo, but take a longer duration to heal, can take up to 2 weeks to heal, and are generally painful. On the other hand, the herpetiform ulcers should not be confused for herpes or etiology being anywhere related to herpes. These are also aphthous ulcers. They are smaller in size, but they are seen in multiple numbers. Sometimes you can see about 100 ulcers in the oral cavity. They are tiny, shallow, and they can even coalesce, very similar to the herpes lesions, herpetic ulcers, to form a larger ulcers. Again, the herpetiform aphthous ulcers are a very painful form of the disease. The etiology of aphthous ulcers could be multifactorial. It is considered to be genetic. There are hematological deficiencies also which could cause the ulcers, such as iron deficiency, folate, and vitamin B12 deficiencies. Immunological abnormalities, local factors such as trauma, or even smoking. Nicotine metabolites, in case of smoking, which is actually surprising, is that nicotine metabolites are believed to decrease levels of pro-inflammatory cytokines, and hence patients with aphthous ulcers um, or smokers rarely get aphthous ulcers. So, but that it doesn't mean that patients who get aphthous should start smoking. It means that nicotine generally, or smoking generally, could increase the keratinization, which perhaps is a causatory factor of lower number of aphthous ulcers in patients who smoke. Microbial agents like streptococci, H. pylori, and even viral diseases like varicella zoster, cytomegalo, HHV6 and 7 also can be etiological agents to induce aphthous formation. Dysfunction of mucosal cytokine network and other, simply stress, could be a reason why patients get aphthous. Anxiety, menstruation, upper respiratory tract infections, and even food allergies could all contribute to the formation of aphthous ulcers. But again, at this point, I need you to understand and remember that the aphthous ulcer is diagnosed as a disease of exclusion, which means that the patient only has oral ulcerations and no other significant systemic involvement. The differential diagnosis for aphthous ulcers must include primary acute lesions like viral stomatitis, specifically recurrent intraoral herpes, and they may look very similar to the herpetiform aphthous that we see previously in the previous slide. But it's important to understand that generally herpetic infections, like other viral infections, are preceded by prodromal symptoms like fever or malaise, fatigue, and could be preceded by vesicles, whereas aphthous are never preceded by vesicles. Ulcer is the primary lesion in aphthous ulcers. Also to be considered as differential diagnosis are chronic multiple lesions like pemphigus and pemphigoid. It's important to remember that even these are preceded by ulcers. So generally the patient history taking is very important, and when there is a history of vesicle formation, aphthous should be ruled out. Recurring ulcers like connective tissue disorders like SLE, drug reaction, dermatological diseases, and even Behcet's disease are all differential diagnoses for aphthous ulcers. And underlying diseases like HIV, GI complaints, associated genital, ocular, and skin lesions must also be taken into consideration. It's important to understand Behcet's disease at this point. Behcet's is a very important differential diagnosis for aphthous, and also the ulcers that are seen in Behcet's disease are very similar to the ones that are seen in aphthous. The etiology of Behcet's is immune dysregulation. There are circulating immune complexes. Autoimmunity and cytokine dysfunction is also thought of as an etiology. Similar to Behcet's disease is magic syndrome, which is a variant of Behcet's. There are mouth ulcers, genital ulcers with inflamed cartilage. That is what is the full form of a magic. And Behcet's is diagnosed clinically with the patient reporting with recurring oral ulcers at least 3 times in a 12-month period in 90% of the cases, and any of the following manifestations such as eye lesions, including uveitis or retinal vasculitis, skin lesions like erythema nodosum, pseudofolliculitis, and papillopustular lesions and acneiform nodules, and an important test which is the positive pathergy test. When a 20 gauge needle is inserted 5 mm into the skin, an indurated papule or pustule forms, which is greater than 2 mm in size within 48 hours. So, this formation of a papule or a pustule is indicative of a positive pathergy test and a very diagnostic indication that the patient could be suffering from Behcet's disease.
Okay, so it's me, Dr. Ajay. Coming to the histopathology of recurrent aphthous ulcers, well, as you know, an ulcer is a break in the continuity of the epithelium. And so, microscopically, what do we see? Right? So, we see a fibropurulent membrane covering the ulcer. You see superficial colonies of microorganisms. We will see intense inflammatory infiltrate, right, which is something common under the base of the ulcer, necrosis near the surface, and granulation tissue at the base. Okay, a typical Anishko cell is also seen in the smears done from aphthous ulcers. Okay, now this is like a fun fact. Now, Anishko cell are basically cells with elongated nuclei containing a linear bar of chromatin. They have radiating process of chromatin extending towards the nuclear membrane, and the nuclear chromatin is arranged along the long axis of the nuclei. Now, a fun fact is that this is also seen in sickle cell anemia. This cell is also seen in megaloblastic anemia, in children on chemotherapy, and even in normal people. Okay, so this presentation in smears taken from the buccal mucosa of these patients as well as aphthous ulcer patients present the cells. This NH cells. This cell typically looks like this. All right. Okay, so coming to Behcet syndrome, which is a common syndrome which is associated with recurrent oral ulceration or recurrent aphthous stomatitis, it is an immune dysregulation. Okay, that means there is a problem with there is an immune defect, and it can be aphthous stomatitis can be differentiated from Behcet's only by an HLA marker. Okay, HLA is human leukocyte antigen, and I'm sure you know about it. It is related to major histocompatibility complex. Okay, the oral lesions in Behcet syndrome are very similar to aphthous stomatitis. Okay, so this is a infographic here of the world geographic distribution of Behcet's disease. Now, Behcet's disease, as I told you, is an immune dysregulation associated with the HLA-B5. Now, it has been noticed that this is very commonly seen, or rather frequently seen, in East Asians and Eurasian populations between Japan and the Middle East, and it has been described. This region is being described as actually the Silk Route, and because it is seen among this population of people, commonly seen among this populations of people, it is Behcet's disease is also called the Silk Route disease. Okay, um, and HLA-B5 and HLA-BW51 is the cause for the Behcet's disease. Okay, coming to the clinical features, it's common among males in the age group of 10 to 45. There is a triad of oral and genital ulceration, ocular lesions, and skin lesions commonly seen. These oral ulcers are painful and are very similar to the recurrent aphthous stomatitis. Genital ulcers are commonly seen on the scrotum or the root of the penis or the labia majora. Okay. This is a picture of a patient who came in with aphthous stomatitis, recurrent aphthous stomatitis, that was eventually diagnosed as Behcet's disease based on the triad of clinical presentation as well as the HLA marker study. Okay. The ocular lesion range from conjunctivitis to uveitis and finally hypopyon. Now, hypopyon is actually the collection of pus in the anterior chamber of the eye. Skin lesions could be pustules or papules. You very well know what they are. Other manifestations that are seen in these patients are pyoderma, erythema nodosum, and erythema multiforme. Complications that have been noted in these patients are arthralgia, thrombophlebitis, CNS and CVS, and respiratory involvement. This is a picture here of a patient who was diagnosed with Behcet's, showing the ocular symptom of conjunctivitis. And this is hypopyon. If you can notice, this is pus that is collected in the anterior chamber of the eye, the severe redness of the sclera, as well as ocular uh, ulceration noticed over here. Histopathologically, again, oral lesions are shows a non-specific ulcer. Typically, an additional feature that is seen histopathologically is vasculitis. That means inflammation around the blood vessels. The lab diagnosis is, when done, shows hypergammaglobulinemia, increased ESR, leukocytosis, and eosinophilia. Treatment here is symptomatic or supportive in measure. Reiter syndrome or reactive arthritis is another uh, syndrome that is associated with recurrent aphthous stomatitis. The etiology is unknown. It is an immune dysregulation seen in HIV positive patients as well. Clinical features include commonly seen in 20 to 30-year old males. A male to female ratio is 9:1. The features that are characteristic of Reiter syndrome is the patient has non-gonococcal urethritis, arthritis, conjunctivitis, and mucocutaneous lesions. Okay, something typically seen in patients with reactive arthritis or Reiter syndrome is keratoderma blennorrhegica, which is actually vesiculopapular lesion on the foot of the patient. Now, these are very waxy and are peel off easily from the patient. Okay.
Let's now talk about chronic multiple lesions. Let's discuss this case to better understand an example. A 41-year-old housewife reported to your dental clinic complaining of painful ulcers in the mouth, which have been troubling her for a few months. She tried using watermelon frost upon her friend's recommendation, but it hardly worked for her. She finds the curry she cooks is very spicy, while the rest of the family enjoys it. Upon further questioning, she also tells you that she has been having skin problems, itchy skin with few sores on the back and arms. Look at the pictures here. You can see the oral cavity. There is a sloughed out ulcerated lesion on the palate, and on the skin there seem to be scab formation and perhaps what were previous ulcers. So, keeping this history and clinical features in mind, what are the investigations that can help you reach a diagnosis? And what is your next course of action as a primary oral healthcare provider? Now, these are pictures from one of our case in the clinic, and it gives you an idea as to what kind of manifestations a patient who has chronic ulcers on the or in the oral cavity as well as the skin could manifest as. So, keeping this in mind, I would like you to bring to the disease that we are discussing now, which is pemphigus. Pemphigus is an autoimmune disease. It has a genetic predisposition and generally seen in Ashkenazi Jews, having a strong association with the HLA, DR4, and DQ8 haplotypes. Autoantibodies are formed against desmoglein 3, which causes loss of adhesion of cells and intraepithelial bullae formation. The various types of pemphigus, the most common one being pemphigus vulgaris, which has a variant of pemphigus vegetans. The bullae occur deep and just above the basal cell layer. Pemphigus foliaceus and its variant Pemphigus erythematosus have bullae which occur in superficial granular cell layer. There are other variants such as the paraneoplastic pemphigus and drug-related pemphigus, which is generally caused by penicillamine and captopril. Pemphigus vulgaris is the most common variant, with 80% of the cases falling under this category. Antibodies against IgG, against antibody IgG, that is against the desmoglein 3, are the reason for mucosal lesions, and against desmoglein 1 are the reason for skin lesions, but both can occur together also. So, pemphigus vulgaris can coexist with myasthenia gravis, thymoma, and lymphomas. Since it's an autoimmune condition, this is something which is important to remember. The clinical features generally seen in fifth to sixth decade of life. Thin walled bullae are seen on the skin and the mucosa, which break rapidly into large areas of denuded skin. Nikolsky sign is positive. This is a very important clinical sign. Pressure, when it is applied to apparently normal skin, results in formation of a new lesion. This results from the upper layer of the skin pulling away from the basal layer, and it forms a new lesion, and this is called as the Nikolsky sign. Oral manifestations are seen in 80 to 90% of the patients, and 60% of the cases, the oral manifestations are the first sign. Generally, these patients report to the dentist with a minor ulcer or noticing multiple ulcers in the oral cavity a few months before the skin lesions actually erupt. Classical bullae are seen on non inflamed base, which break into shallow ulcers, and there is irregular peeling of the epithelium in the oral cavity, leaving mucosal tags. Generally, ulcers start in the buccal mucosa due to trauma, and they could also be seen in the palate and gingiva. Early treatment of the disease is very important, and it gives easier and it is easier to control. And generally, since the diagnosis is difficult, it generally takes about 5 months for diagnosis on an average till the patient actually gets diagnosis as pemphigus. So what happens is like the case that I told you, where we discussed in the beginning. Most of the time, the patient assumes that the ulcers would just go away and they would do some home remedy. But it so happens that only when the skin lesions arise, and it becomes worsened, it would have already been existing for 5 to 6 months before the patient actually um, opts for medical care. So, differential diagnosis of pemphigus ulcers, you must understand that these are chronic lesions and they're multiple lesions. So, some acute conditions like viral infections or erythema multiforme or recurrent aphthous ulcers can also form the differential diagnosis, and the ulcers in the oral cavity can look very similar to any of these diseases. Desquamative gingivitis is something important that we need to consider. And mucous membrane pemphigoid as erosive lichen planus also manifest in a very similar way as pemphigus vulgaris in the oral cavity when the gingiva is affected. So these are some clinical images of how pemphigus can appear in the oral cavity. You can see large ulcers and a severely denuded area. The ulcers are not defined like how we had seen the aphthous ulcers. They're very diffuse, irregular borders. They can be shallow and can be extremely painful. So, as you can see in the images, the buccal mucosa, vermilion border of the lip, labial mucosa, and even gingiva can get affected. So, when the gingiva gets affected, it's important to take note. It's an extremely painful condition, and they could be bleeding on brushing, and it should not be confused with periodontitis or simple gingivitis.
Okay, so coming to investigations in this case, patients who come with suspected pemphigus. So the first investigation that we can do, or chairside investigation that we can do, is called the Zank test or the Zank smear, which is basically rupturing an intact vesicle or a bullae, collecting the fluid and making a smear just like we make an oral smear to look for Zank cells. Now, Zank cells are basically degenerating epithelial cells, which were of great significance in the diagnosis of pemphigus before the advent of immunofluorescence testing. All right. So, anyways, that's the first test. The second test is histopathology of the biopsy specimen. That means the clinical picture that you've seen in the previous slide. Once you see the lesion, you actually do the biopsy. The biopsy here in this case is done from perilesional normal tissue. Okay, we do not take the center of the vesicle or the ulcerated area, but the perilesional tissue. And third investigation is direct immunofluorescence, which helps us to come up with the confirmatory diagnosis. Right, this is the high view of histopathology of pemphigus. These are the basal cells. This is the supravascular split. These floating uh, cells that we see here around in the split are the Zank cells or degenerating epithelial cells. The confirmatory diagnostic test for pemphigus is immunofluorescence. Okay, so immunofluorescence, I will explain what it is. So there are two types: direct immunofluorescence and indirect immunofluorescence. So direct immunofluorescence, please remember, is done on tissue biopsies. Okay, so that means they have to be done only on tissue biopsies, whereas indirect immunofluorescence is done on specimen, that is blood specimens that are collected from patient. Okay, so that is the biggest difference. The rest of it you will understand. So fluorescence is the emission of light of one color while a substance is irradiated with the light of a different color. Okay, so in direct immunofluorescence, conjugated anti-sera is directly added to the tissue section, that is the tissue that the biopsy that we have done. So here in this case it's frozen tissue section, and we add conjugated anti-sera onto that and then visualize it under immunofluorescent light, okay, under fluorescent light. Indirect immunofluorescence, on the other hand, is employed to detect antibodies in serum or other body fluids. Okay, so anti-human globulin fluorescent conjugate is employed to detect any antigen antibody reaction. So if you notice, antigen antibody reaction is what is identified in an indirect immunofluorescence, whereas direct immunofluorescence, what we actually identify is the conjugated anti-sera that binds to the antigen. So this is the infographic to explain indirect and direct. So if you see in the direct immunofluorescence, you have the antigen, and then uh, the primary antibody with the fluorophore is added onto it. It binds to the antigen, and then this is detected through the fluorescent microscope because of the fluorophore that is visualized. Whereas on the in the indirect immunofluorescence, uh, there's a tissue slide which contains the antigen and the antibody reaction already, to which the serum or the blood serum or body fluid is attached, which is conjugated with the fluorophore. So the secondary antibody with the fluorophore, which binds to this antigen antibody reaction, that is visualized. That is indirect immunofluorescence. So again, I'd like to repeat: direct immunofluorescence is done on tissue. Indirect immunofluorescence is done. So once the fluorophores bind to the antigen antibody reaction, the tissue is visualized under fluorescent microscope, and then you can see the deposition of IgG and oblique or the C3 complement 3 in the intercellular spaces of the epithelium. Okay, which is the area for desmoglein 1 and desmoglein 3. So basically, this is how it looks like. It looks like a fish scale appearance or a chicken wire appearance under fluorescent microscope. So here is a comparison between the histopathology and the direct immunofluorescence of Pemphigus vulgaris. If you look here, I'll go through again. You see the suprabasilar split. You're seeing the zinc cells. On the direct immunofluorescence, however, you are seeing the the IgG and the complement 3 expression through the fluorophore identification, which the pattern of arrangement is chicken wire arrangement or fish scale arrangement. Thank you.
The treatment of pemphigus, it's very important to remember that early diagnosis is the key. If oral lesions are diagnosed and treated early, there is a very high chance that the disease progression can be controlled. So, this is very important for the dentist and the role of the dentist here in identifying patients who could be having chronic oral ulcerations and not brushing them aside as normal aphthous and trying to treat the patient repeatedly. So it's important to understand that patients who do complain of chronic ulcers must be investigated. So, the mainstay of treatment for pemphigus is steroids. Patients can be put on steroids for up to 1 to 2 milligrams per kg per day. And prednisone, short courses are generally the ones that are used as to start off with treatment. Also, topical steroids, such as in the form of gels, mouthwash, medication, and a soft lint, and a systemic application of steroids, or both topical and systemic, can be used. Other adjuvants which are used along with steroids to reduce steroid dosage and its complications are immunosuppressants like azathioprine, cyclophosphamide, or mycophenolate mofetil. Parental gold, dapsone, and IV immunoglobulins have also been tried. But having said that, most of these adjuvants are generally better to be started off in a medical setting or in a hospital environment. Let's move on to bullous pemphigoid, which is also an autoimmune disease. The binding of autoantibodies to specific antigens in laminal lucida of the basement membrane causes this disease. Generally the hemidesmosomes are involved, and vesicles are seen in the subepithelial region of the epithelium, so subepithelial region. So this is a self-limiting condition and less severe than in comparison to pemphigus. It can last for a few months to up to 5 years, and the patient could go into self-remission, or it's rarely life-threatening, and generally can occur in conjunction with multiple sclerosis, malignancy, or even drug therapies like diuretics. The clinical features are adults greater than 60 years old. Skin lesions are seen as blisters on an inflamed base, and they generally do not continue to extend and cause denudation, unlike pemphigus. The oral manifestations are seen in 30 to 50% of the cases. The ulcers are smaller, less painful, and there is no extensive labial involvement as seen in Pemphigus vulgaris. Desquamative gingivitis can also be seen, and it's important to remember that bullous pemphigoid in the oral cavity is difficult to differentiate from mucous membrane pemphigoid. So this is an example of how bullous pemphigoid looks like on the skin of an elderly person. On the arm, you can see the large bullae, and the immunohistochemistry or direct immunofluorescence image of bullous pemphigoid. You can see the autoantibodies which are seen on around the lamina lucida of the basement membrane. Mucous membrane pemphigoid is also called a sequestratial pemphigoid. It is also an autoimmune disorder and a chronic condition. It primarily affects the mucous membranes, and that's why the name. Autoantibodies are seen against proteins in basement membrane, generally the lamina lucida region, and involving the epiligrin protein. Clinical features generally seen in patients who are greater than 50 years of age. Female to male ratio is 2:1, and any mucosal surface can be involved, which causes the lesion to appear in the form of bullae, which later form ulcers and widen a larger ulcerated area and cause scarring. So it's important to remember that mucous membrane pemphigoid can leave scars on the mucosal surfaces. So the oral mucosa again is the most common mucosal surface involved in 90% of the cases. Conjunctiva can also be involved, which is the second most common site. And when scarring occurs, an important terminology to remember would be a symblepharon. It is a scarring seen between the bulbar and palpebral conjunctiva, which can lead to blindness in the patient. Genital and esophageal lesions can also be seen. Skin lesions are lesser, obviously seen, and seen in only 20 to 30% of the cases. In the oral cavity, it can also manifest as desquamative gingivitis, like we discussed, similar to pemphigus and bullous pemphigoid. This is an example of clinical features of a mucous membrane pemphigoid, where you can see the exposed connective tissue which appears as red areas, in the and epithelium which is about to slough, which appears as white areas, and symblepharon in the oral in the conjunctiva because of scarring due to the scarring of the palpebral as well as bulbar conjunctiva. This is the histopathological image of subbasilar clefting, which is evident, and that is the area where the bulla is formed. This is a case of desquamative gingivitis, and the gingiva appears extremely erythematous, and you can see that does not look similar to periodontitis or simple gingivitis. Of course, it is a very painful condition, and the gingiva can bleed easily upon touch. On the top left corner, you will be able to appreciate that there is a mucosal tag closer to the canine attached gingiva. So that is exactly an example of how the epithelium appears to be peeling off. So the differential diagnosis for this sort of desquamative gingivitis is erythematous or erosive lichen planus, and pemphigus, mucous membrane pemphigoid, linear IgA disease, erythema multiforme, and even lupus erythematosus. Now, it's important to remember here again that desquamative gingivitis itself is a condition and is not a diagnosis. It is the appearance of the gingiva which is diffusely desquamated, or epithelium is desquamating, and is an extremely painful condition. And this is a clinical image of how it can look like in the oral cavity. The etiology of desquamative gingivitis could be any of these diseases that are mentioned here. And again, important to remember that this is not simple gingivitis or periodontitis. Let's move on to the last part of the lecture series, which is single ulcers. Traumatic ulcer is the most common cause of single ulcers in the oral cavity. They generally happen due to direct trauma to the oral mucosa, either because of a mechanical, thermal, or chemical agent. The mechanical causes of trauma and leading to traumatic ulcers in the oral cavity could be generally biting after local anesthesia is given, Malocclusion leading to constant trauma because of a sharp or malposed tooth, ill-fitting dental prosthesis, faulty toothbrushing habits, or even flossing, self-injurious habits, which are also called as masochistic habits, or oral piercings. Thermal agents leading to ulcers in the oral cavity could be electric burns, hot foods, very commonly, like a pizza burn, which generally causes a traumatized mucosa or an ulcer on the palatal mucosa. Dental instruments accidentally causing hot dental instruments, which have, just been autoclaved, if you use it in the oral cavity of the patient, could lead to thermal burns. Chemical causes of a traumatic ulceration or traumatic ulcer could be an aspirin burn. In patients who keep the aspirin tablet directly in the oral mucosa, could lead to a caustic chemical reaction in the area. Mouthwashes with very high alcohol content can also cause chemical burns in the oral cavity, or also chemical reaction which can be looking like a traumatic ulcer. Hydrogen peroxide used as mouthwash, phenols, methacrylate monomer, denture cleansing agents used as an oral rinse, and even endodontic chemicals which are pushed beyond the apex may cause necrosis of the bone. So these are some pictures to show you potential sources of injury, right from loose electric wires, which have known to cause damage as well as burns even in infants, something which is important to look at. And pizza burn, for an example of a thermal burn, or even sharp, accidentally sharp areas which can cause sharp instruments or sharp cutlery, or even toothbrushing, which can lead to traumatic ulcers in the oral cavity. The differential diagnosis for traumatic ulcer, it is important to remember the history and physical findings which help in diagnosis. And the squamous cell carcinoma should definitely be ruled out. Patient must be re-examined and for healing within 1 to 2 weeks. And if it doesn't heal, the patient must be advised biopsy to rule out squamous cell carcinoma. Infectious diseases or also chronic ulcers can form differential diagnosis for a single traumatic ulcer. For example, deep mycosis like histoplasmosis, blastomycosis, mucormycosis, aspergillosis, though rare, can lead to single ulcers in the oral cavity. And syphilis also can have oral ulcers in the primary and tertiary stages, which could be confused for a traumatic ulcer. Management of traumatic ulcers, number one is to remove the irritant or the source, pain control in the form of topical anesthetic gels or agents, and antibiotics rarely but are given to prevent secondary infection in cases of extensive lesions. This is an example of malignant ulcer, a single ulcer and ulceroproliferative lesions seen in oral squamous cell carcinoma. And deep fungal ulcers, like I told you, rare but can be seen in patients who are already having an underlying systemic disorder. Examples would be histoplasmosis, blastomycosis, mucormycosis, which was recently seen in the COVID times due to existing immune compromised state, as well as aspergillosis. So that brings me to the end of this topic on ulcerative lesions. These are the references, and if you do have any doubts, please feel free to contact me. Thank you.